Here are 10 Puerto Rico Medical Board-style clinical vignettes focused on acute and chronic kidney disease, nephritic versus nephrotic syndrome, each with 4 answer choices and detailed explanations. Renal Pathophysiology, clinical vignettes. 1. Acute kidney injury, prerenal versus intrinsic. A 62-year-old male with hypertension and heart failure is admitted with dehydration and hypotension. Lab results show bun creatinine ratio 25:1, urinary sodium 20 milliliter/1%. What is the most likely cause of his acute kidney injury, AKI? A. Acute tubular necrosis. B. Prerenal azotemia. C. Postrenal obstruction. D. Rapidly progressive glomerulonephritis. B. Prerenal azotemia. Explanation: prerenal AK results from hypoperfusion, e.g. dehydration, heart failure. The high bun CR ratio, 21 and low 1%, suggest intact tubular function with sodium retention. 2. Acute tubular necrosis, classic lab findings. A patient with sepsis develops acute kidney injury. Urinalysis shows muddy brown casts. Lab findings include bun CR ratio FENa 2.5, which is the most likely cause of AK, A. Prerenal azotemia, B. Acute interstitial nephritis, C. Acute tubular necrosis, postrenal obstruction. Answer C. Acute tubular necrosis. Explanation: ATN is the most common cause of intrinsic renal failure in sepsis, ischemia, or nephrotoxins. Muddy brown casts and FENa 2% indicate tubular damage. 3. Chronic kidney disease, stages and symptoms. A 54-year-old female with long-standing diabetes mellitus presents with fatigue, pruritus, and nausea. Lab tests show GFR 18 milliliter/min or 1.7 m², serum creatinine 5.2 milligrams per deciliter. Which CKD stage does she have? A. Stage 2, B. Stage 3A, C. Stage 4, D. Stage 5. Answer D. Stage A CKD staging is based on GFR. Stage 1, 90, Stage 2, 60 to 89, Stage 3A, 45 to 59, Stage 3B, 30 to 44, Stage 4, 15 to 29, Stage 5, end-stage renal disease SRD. NASHA. 4. Nephrotic Syndrome. Clinical features. A 7-year-old boy presents with periorbital edema, proteinuria 4.5 grams per day, hypoalbuminemia 2.1 gram blah, and hyperlipidemia. What is the most likely diagnosis? A. Minimal change disease. B. Post-streptococcal glomerulonephritis. C. IgA nephropathy. D. Membranoproliferative glomerulonephritis. Answer A. Minimal change disease. Explanation: Nephrotic syndrome is defined by proteinuria 3.5 grams per day, hypoalbuminemia, hyperlipidemia, and edema. Minimal change disease is the most common cause in children. Nephritic syndrome, hematuria, and inflammation. A 24-year-old male presents with hematuria, hypertension, and RBC casts 2 days after a URI. What is the most likely diagnosis? A. IgA nephropathy. B. Post-streptococcal glomerulonephritis. C. Membranous nephropathy. D. Focal segmental glomerulosclerosis. Answer A. IgA nephropathy. Explanation: IgA nephropathy, Berger disease, presents as gross hematuria within 1 to 2 days of a URI, Synpharyngitic hematuria. PSGN, in contrast, occurs weeks after infection. 6. Post-streptococcal glomerulonephritis, PSGN. A 10-year-old boy presents with dark urine, periorbital edema, and hypertension 3 weeks after a streptococcal throat infection. What is the most likely finding on renal biopsy? A. Mesangial IgA deposits. B. Subepithelial humps of immune complexes. C. Tram tract basement membrane thickening. D. Focal segmental sclerosis. Answer B. Subepithelial humps of immune complexes. Explanation is characterized by subepithelial humps of immune complexes, IgG-C3, on electron microscopy. It presents weeks after a streptococcal infection. Hash 7. Rapidly progressive glomerulonephritis, RPGN. A 45-year-old male presents with rapidly worsening renal function and pulmonary hemorrhage. Renal biopsy shows crescent formation. What is the most likely diagnosis? A. Alport syndrome. B. Goodpasture syndrome. C. Minimal change disease. D. Membranous nephropathy. Answer B. Explanation: Goodpasture syndrome presents with crescentic RPGN pulmonary hemorrhage due to anti-GBM antibodies. 8. Diabetic nephropathy, first manifestation. A 50-year-old diabetic patient is found to have microalbuminuria 30 to 300 milligrams per day. What is the first-line treatment? A. Thiazide diuretics. B. NSAIDs. C. ACE inhibitors. D. Calcium channel blockers. Answer C. ACE inhibitors. Explanation. ACE inhibitors ARBs reduce intraglomerular pressure and slow progression of diabetic nephropathy, which starts with microalbuminuria. 9. Nephrotic Syndrome, membranous nephropathy. A 55-year-old male with hepatitis B presents with nephrotic syndrome. Renal biopsy shows spike and dome pattern on silver stain. What is the most likely diagnosis? A. Focal segmental glomerulosclerosis. B. Minimal change disease. C. Membranous nephropathy. D. Amyloidosis. Answer C. Membranous nephropathy. Explanation. Membranous nephropathy is associated with hepatitis B, lupus, and solid tumors, showing a spike and dome appearance on biopsy. 10. Lupus nephritis classification. A 32-year-old female with a SLE presents with nephrotic range proteinuria, hematuria, and RBC casts. Renal biopsy shows wire loop lesions on electron microscopy. What is the most likely class of lupus nephritis? A. Class 1, minimal mesangial. B. Class 2, mesangial proliferative. C. Class 3, focal. D. Class 4, diffuse. Answer D. Class 4, diffuse. Class 4 lupus nephritis, diffuse proliferative, is the most severe form, presenting with wire loop lesions, subendothelial immune deposits. Key takeaways for renal pathophysiology: prerenal high bun-sear ratio, low FENa, and muddy brown casts, FENa than 2%. Nephrotic syndrome, proteinuria 3.5 gram per day, hypoalbuminemia, hyperlipidemia. Nephritic syndrome, hematuria, hypertension, RBC casts. Occurs weeks after strep infection, subepithelial humps. IgA nephropathy, Synpharyngitic hematuria. Diabetic nephropathy, first sign equals microalbuminuria. Would you like a set on renal tubular disorders?